Hello, everyone. Welcome to week 10. This week, we're going to talk about the middle end processes in the revenue cycle. And again, these middle processes are the resource tracking. These involve such things as coding, the charge master, and others. So a term that you hear a lot is charge capture, and this is basically accounting for everything that is a billable service or supply that the patient gets in an encounter. Could be a hospital, could be a clinic, could be urgent care, but either way, if they're getting a supply or a service, those supplies or services cost money. So we want to make sure that we're charging everything and capturing everything that we're entitled to process. And how this relates to coding is we assign alphanumeric strings of codes to these diagnoses and procedure codes so they can be reported to the payers. And again, as it talks about here, there is facility coding, in other words, the codes for the facility where the service is being rendered, professional coding, which is the technical component in CPT, in other words, what the physician is or provider is coding and billing, and then there's single path coding. Single path coding involves people coding both the facility and the professional coding. So we'll take a closer look at those. And again, when we think about patient care services, as we've learned throughout the course, we're talking about things such as case management, room rate, unit charges. Each medication, each suture kit, whatever it is, has a cost, and those are chargeable. One of the things that is hugely important to think about is computerized provider order entry. We've talked about this in your other courses. And basically, with the computer, we don't have to rely on people interpreting things that can barely read, as we had to do in the paper chart world, to apply code and bill it. Now, of course, every time we dispense a medication, frequently there's a barcode, we scan it, it enters the order and what have you. And then it links up to the charge description master. And basically, you can think of this as a giant relational database or data table, as it says here, that links a lab test, an imaging test, what have you, to a fee. Right. One of the things that's good about computer orderized entry, if we're thinking back to some of these other reimbursement models, is that providers can order tests, but they should be related to medical necessity, right? So in some electronic health record systems like Epic, every computerized order has to be gridded or matched to a potential diagnosis. And this is cut down on a lot of superfluous, unneeded tests. And again, the charge description master, or the charge master, as many of us say, is typically managed in the hospital accounting or the finance department. And it's the shared responsibility with the clinical labs, the ancillary areas, and of course, health information management. And the way the charge description master is used is we hard code these certain services, these procedure codes, lab codes, what have you, to a fee. And as a result, we need to have a close working relationship between health information management and the people that are over the charge description master. And you can see these things illustrated in figure 10.1 or 10.3 in your text. And again, the charge code, we have one here, 1, 2, 3, 4. We have a department number, a revenue code, a HCPCS code. And then the charge. And these will vary based on facility and all the other variables we talked about earlier in the course. And these could either be coordinated distribution or unique. So in other words, with the coordinated, we have a straight numerical order, and for example, reserve services for PT. Otherwise, we have unique. And the unique types of charge codes is basically making sure we don't have duplicate charges. And again, this is a great area for people who are new to health information management, who maybe are newly graduated RHITs or what have you. A lot of them start off here with working with the charge master. And again, you may want to take a closer look at table 10.5 in your text that covers CPT and the HCPCS level 2 and the other coding sets, specifically ICD-10-CM for diagnosis coding, ICD-10-PCS for hospital-based coding. And again, where do these come from? A lot of people are kind of surprised to hear sometimes that we are looking at ICD-11, which is now released by the World Health Organization, who, of course, are the people who brought us ICD-10 and others. And it will be used by the CDC for acute illness and mortality reporting. Again, the United States is not on ICD-11. Right now, we're on ICD-10-CM. For those of you who have taken HIM 270, this will be pretty straightforward. We have certain things, the category code, the first 3 characters, and then we have the 7th character, which talks about whether it's an initial encounter, subsequent encounter, sequela. We have subcategories, right? We have laterality, all these things that are specific to ICD-10-CM. With the PCS code, this was developed in the US to report inpatient procedures, a little bit different than ICD-10-CM. ICD-10-CM was developed by the World Health Organization and then implemented here for clinical modification in the United States, hence the 2 letters CM. PCS was developed by the US to report all the inpatient procedures. It was implemented October 1st, 2015, and it's different from the rest of the world. We do different procedures, we have different code structures, and what have you that are different from the rest of the world. So ICD-10 PCS is unique to the United States of America. And again, for those of you who have taken ICD-10 PCS courses, this will be familiar. But basically, in a lot of ways, it is giving you more granularity, more detail than your diagnosis coding. You have a body section, body system, you have a root operation, a body part, how it's approached, whether they use the device, and qualifiers, right? So in this example here, right, we have an excision, we're doing a mitral valve procedure, so it's medical and surgical, that's the first category. So it's going to be G, or I'm sorry, 0, and then the body system going to be 2 for the heart and great vessels. It's going to be B, it's going to be an excision, which means cutting off a portion of a body part. And then the approach, if we do it through an open approach as opposed to endoscopically, it's going to be 0. Then if we didn't use a device, no device, and then a qualifier, in other words, what's the reason we did it? It's diagnostic. So it's X. And if you've taken the ICD-10-CM courses or PCS courses, you're familiar with these guidelines. And the guidelines are basically developed by the NCHS, CMS, AHIMA, and the American Hospital Association. Within that, we have coding clinic for ICD-10-CM and ICD-10-PCS that comes out quarterly. HCPCS, as it's commonly referred to, is Healthcare Common Procedure Coding. Level 1 HCPCS is CPT, which you learned about in CPT coding. Level 2, which you probably touched on, I'm sure, in the CPT coding, is the HCPCS codes. CPT is used to report all these diagnostic and surgical procedures. Right? So it's owned and it was created by the American Medical Association. And in 1985, adopted by HCPCS, became known as HCPCS Level 1 for Medicare reporting. But of course, that means that we also have Level 2, which we'll get into in just a bit. How is CPT used? It's used by physicians for inpatient services and procedures for the pro fee. It's used by facilities for ambulatory surgery center services and procedures. Right. So again, when you think about these things, think about what is pro fee and what is facility. And you can see some examples of CPT here, right? Category 1, the CPT we're familiar with, these are 5-digit numeric codes, repairs, right? Sutures, what have you, as you can see here. Category 2 is data collection codes, and these are alphanumeric codes. So if you assess tobacco use, you're going to use 1000F. And then category 3 is new technology codes. So these are the things that are coming online. You can see an example here with 0085T. And that's all I have for you. We'll see you online. Tune in to the next video lecture where we'll talk some more about coding sets and reimbursement. Bye now.